Welcome to LOA Today. I'm Walt Thiessen.
With me today is financial advisor Jody Lynn Craven.
This is your daily dose of happy. We are so happy you decided to join us today.
Now, of course, you all know Jody Lynn is a financial advisor, and she is on the show primarily because that's how she came to us, but also because she's wonderful, and she also has a great grasp on a lot of the topics we talk about here. But lately, Wednesdays have become medical Wednesdays because last week we had a children's chiropractor named Dr. Vic Manza back for a second visit. And this week we have an orthopedist joining us today. So I don't know. We got a theme going on here, Jody. Have you figured this out? Out.
No, that's exactly what I was thinking when I saw the email of who was going to be on the show. I was like, wow, it's become Doctors Wednesday.
That's right. Yeah. So without further ado, let us welcome Dr. Doug Lucas, who is an orthopedic surgeon. And he has a rather interesting story. We often talk here on the show about health related stuff. And when we do, often the conversation gets into mainstream medicine versus alternative medicine and all that kind of thing. And we don't encounter in life a lot of people in the mainstream medical community who embrace anything in the alternative community. So when you encounter somebody who does that, it's like, oh, it's like an eye opener. And that's exactly what the case is with Dr. Lucas. So, Dr. Doug, thank you for joining us today. How are you today, first of all?
I'm doing wonderful, and thanks for having me on, Walt.
And give us a little bit of that background. How did you end up, my God, did you actually like break a rule somewhere in the medical community? You went outside the norm?
Yeah, I've been shunned. No, that's not true. So,
I wouldn't be surprised.
Yeah, no, I mean, we can talk about the reaction to this move, which has been interesting, but yeah, I'm traditionally trained as an orthopedic surgeon. I went through all of the traditional, medical school, 5 years of residency, a year of fellowship, focusing on orthopedic surgery with the goal of, practicing traditional orthopedics. And I did that for 7 years. What really drew me away from it was my experience through talking to my patients. Once I got into practice, really understanding, what my patients were going through and why they ended up in my office, and recognizing that so much of what they were there for didn't need to actually happen.
Wow.
And by the time they got to me, we didn't really have very many choices, other than, okay, let's operate. But especially in the foot and ankle world, we can make things different. We can make things better, but it is way better to prevent it if you can. And so that's why I shifted that focus. And part of what helped me to do that was my wife, while I was going through medical school, she got her PhD in nutrition. And when I started practice, she started a business in weight loss and nutrition optimization. And when she first told me, hey, I reversed my client's diabetes, I looked at her like she was nuts, because that's not what we're taught, right?
Yeah.
You can't do that. And as usual, she was right. And we started kind of looking into the research together, because at that point there wasn't a lot of good evidence behind actually doing that and taking that approach. And she was really reversing diabetes. And yet I was seeing these patients that had diabetes and, they had terrible disease, but they were following all the recommendations and taking their medications. And yet they still needed surgery after surgery and potentially even losing their leg. And so that really catapulted me into looking into what else is out there and how could I potentially educate people in a different way.
That's fabulous. I congratulate you, first of all, for taking that leap. That's because let's be honest, there is a significant amount of pressure within the mainstream medical community to not go beyond the edges. And you took that leap. So congratulations for doing that.
Thank you. Yeah. And you're absolutely right. When I would talk to my peers about, hey, I'm thinking about doing this, or I want to learn more about, hormones is another good topic to talk about. But, I want to, why are we so afraid of this thing? And why aren't we doing that? They look at me, they're like, dude, just do your job. Like just you be happy with what you're doing. You got a great thing going. You're getting paid well. Just do your job. And that always rubbed me the wrong way. Because you're right. I could just put my head down and do my job and make the money that we were making, which was good.
Sure.
But I wasn't happy. I wasn't in a place where I felt like I was doing my best service to those around me.
That's an interesting question too, about well, not so much a question, more of a topic, I guess, about that sort of circle the inner circle that you're not supposed to breach the boundaries of. And I guess the question I'd like to ask you is, why do you think there is so much resistance, and what do you think it's going to take for that boundary to expand?
Ooh. I mean, within the medical community, there is, over the last several decades, as the hospital systems have gotten bigger and the insurance companies have gained control, and the pharmaceutical companies, there is less and less interest in physicians thinking outside of the box. The system is built around us as widget makers making widgets. And if we are noisy, they don't like it. And it's really unfortunate because we've created a system where physicians they're given a lot of information. Most of it's outdated by the time they start practice, but they're given a lot of information. And then they're given guidelines. That's really
encouraging, I have to say. I mean, my God,
it's just, and it's not their fault. And it's not even the medical school's fault either. The curriculums are created the way they are. And there is such a tremendous amount of information to provide that it really is an impossible task. But the system is built to sort of put up the guardrails and say, well, there's so much information, so we're going to give you guidelines to practice. We're going to subspecialize everybody because there's so much information. And then none of us know anything about any other field. And we really can't do anything else. Right? I mean, as an orthopedic surgeon, I was in such a narrow box that I didn't even know, what my hand partner did, who did almost the exact same training except a different fellowship. Right? And he's doing surgeries that I've never heard of. So imagine, when I start talking about things that are happening in the endocrinology office or things that are happening, in the OBGYN office, and people look at me like, dude, you don't know enough. And they were right. I didn't know enough, but I got more training.
And that's part of the secret, isn't it?
Yeah.
That's right. Ask more questions, but then get it from the right sources, and so that's why I did 2 fellowships as I was making that transition out.
You're actually doing a nice job of answering another question that's been in the back of my mind, and actually I've been bringing it to the forefront a little bit lately, and that is the medical community, medical science is based in at least theory and often in practice on science. And the thing that has struck me for the longest time is that there is so much that gets done within the medical community that starts with science and then makes some assumptions and turn that into a protocol. And I don't quite I do get that because you can't have, there's no way to have enough information. You're constantly chasing information. And so I get that part. I guess the part that I have trouble with is, okay, that goes on, but anybody else who goes a little bit loose on the evidence, oh no, they get a different standard applied. That's the part I have trouble understanding.
Yeah, it's a huge challenge because we do say in the medical community, where is the evidence? Follow the evidence.
Right.
But if you look at the way we treat our patients, so much of how we treat is based off of dogma. It's based off of, traditions passed on from generation to generation that was never based on evidence in the first place.
Wow.
So many of the things, or I shouldn't say never. I should say that it was based on evidence at the time, which probably wasn't very good because we didn't do good studies. If you go back 50 years, how many double-blind placebo-controlled trials were conducted in the 1940s? Not many.
Not many at all.
And yet that's where a lot of our protocols are still passed on from generation to generation. And it's hard to get past that dogma. It's hard to question the way that your trainer trained you. And that's why we're trained to look for, okay, well, where is the good evidence to say that I shouldn't do it this way? But the problem with that is that a lot of the things that, especially in the world that I live in now, these studies will never be done. The studies that are going to refute some of the hormone studies that said that hormones were dangerous, the studies to refute that will never be done because pharmaceutical companies aren't going to make those drugs. So there's no funding to do it. Or where is the studies on the nutraceuticals? In the supplement world, such a challenge because there's just not enough money to be made to fund $1 billion study to prove that this one thing does what we think it does. And so we look to say, well, where is the evidence that what you're doing is the right thing to do? And I say, well, we use the best science that we have, but then you have to use your training and you have to try to put it together on a person to person basis. But then to say that is a faulty model, but then go back to doing the dogma that was based on an expert opinion from 1920, I don't know that that's better.
Yeah.
And so it's a really challenging way that I struggle with because I'm doing things that are outside of the box, obviously, but I still communicate with traditional healthcare providers. So when a patient tells me that, oh, their primary care doctor, doesn't want them to do this thing because it's not in the guidelines, will you chat with them? It's like, ooh, well, I can. I'm not going to convince them otherwise, though. They just don't understand.
Yeah. But it does raise a very interesting problem, and I think you very eloquently expressed it, which is the only entities that can afford to do studies anymore are pharmaceuticals, right, which is going to pretty much limit what you're going to study.
Or the federal government, yeah.
Well, or the federal government, yeah, to a lesser extent, but certainly there's at least some funding that goes on there. But nevertheless, most of it is going to come through pharmaceuticals. So it kind of raises a question about the gold standard of the double-blind placebo study, right? Right. Because if you're only going to go through one entity, then I guess, how would I phrase the question? How much can we rely on double-blind studies?
Yeah, I mean, there's no doubt that if you want to prove that an intervention does something, it's the best way to do it. But you have to then address the reality. And this is where, the blanket statement of, follow the science, where's the science? Well, you have to really understand the science, which is, what is a placebo-controlled study? It implies that there is a placebo that you can actually give to somebody. And a lot of the things, in a pharmaceutical world, yeah, you can give somebody a placebo, right? You give them a capsule with nothing in it, and yeah, it's a placebo. But what about procedures? How do you how do you do a sham surgery? How do you do, sham acupuncture? How do you do sham chiropractic manipulation, like your last guest, right? Like when you lay hands on somebody, you're doing something. You're imparting energy to that person. So it's very difficult to prove through that model that some of these things work. But there are lots of other ways to do research. But the person that, the snobby research consumer will say, well, that's not a placebo-controlled trial, and turn their nose up at it. And I just say, well, you're right. And, and you don't have to do it. But I treat my patients based off of evidence from other things. And, you can look at, prospective studies that are cohort and not placebo-controlled trials and learn things. There are other ways that you can learn about the effect of consuming something or taking something or doing something without having a placebo-controlled trial.
And plus there's another part of the whole placebo issue that I find to be fascinating. And I have to admit, I'm kind of, on the one hand, I'm not surprised. On the other hand, I'm kind of distraught that nothing is actually being investigated in this area. In that, I actually had a placebo researcher on the program one time about, actually it was right after the start of the pandemic. And she was talking about a COVID-related, research she was doing. I said, oh, this is so exciting. Well, she couldn't tell me about it because she was in the middle of it. But I was really, really excited to find out what was going to be. I had to wait a year, found out a year later it was about pain relief. And I have to admit, I was a bit disappointed because what I really want to hear about is research into the power of the human mind to make yourself sick or to make yourself well. And it all seems to be related to just pain relief, which is understandable. I mean, that's where the whole idea of the placebo came from. It came from, World War II. They didn't have enough, morphine to treat the soldiers. So they gave them fake morphine and they felt better. So yeah, I get the pain relief side, but isn't there like a whole lot more that could be explored there?
Oh yeah. I mean, it's funny that when people ask me about, especially certain things that have a very low risk threshold, because I deal in the world of hormones and the world of peptides and the world of supplements. And, people say, well, is there really good evidence behind it? And, frequently in the back of my mind, I'm thinking, well, the likelihood that a placebo is going to have a positive effect is between 30 and 50%. So if this is a very safe placebo that helps them, I'm actually okay with that. Right? Because you're just helping somebody to wrap their mind around the fact that something is helping them. Now, I would prefer, like, as you said, I mean, if you could just deal with the mind, that would be great. But not many people are open to that, to just say that, just somehow you say you actually don't have pain, or let's talk about what that pain means. What is it? What do you mean by pain? Pain's a tough one. But we do see it change without actually changing anything physically, right? I mean, there is so much of an emotional and mental component to it. So yeah, I would love to be able to manipulate that more than I do. But I would be lying if I didn't say that there's some component of placebo in what I do. Obviously I don't want it to be all of it, but it's probably there.
I would think it would have to be. Yeah.
Well, and your belief system too would play into it a lot as well. I would think,
Sure.
your belief that it actually works. You said, your energy when you're laying hands on someone else. It's not about like even just the physical of seeing, the chiropractor and hearing the chiropractor adjust you, or the acupuncturist stick needles in you, or whatever.
Right.
Or you go into surgery and maybe they don't actually do anything for you, but it's also a component of your energy and you're a part of that process too. And I think that's phenomenal.
Yeah. Yeah. And I think what's really interesting as a parallel to that is people have questions too about, I'm in a fully virtual space now, and so I'm not physically laying hands on people, even though I'm trained to do it. Like as a DO, I'm trained to lay hands on people. But I think that even virtually, you can still impart. There is an energy that you can communicate just through your eyes and through your movements. And I see that in my patients, and they tell me that in their follow ups. Just that the interaction, the conversation. I mean, there is a way to impart energy through the internet, which I really don't know how that works. But
I love hearing a doctor say that. That's great.
Yeah, I have no idea how that works. But I mean, because I do hear people that say, well, you shouldn't practice exclusively through telehealth because there's so much that you learn by being in front of somebody. And it's true. You certainly can learn by being in front of somebody. But I can treat people across the country, and they're not going to get to me otherwise.
Mm-hmm.
So let's talk about that some more. Oh, I'm sorry. Go ahead.
Yeah. No, I was just going to add to that. Because I have a financial brokerage and then I have a coaching company, and with the financial brokerage, when the pandemic happened, everything went virtual. And it was going from sitting kneecap to kneecap with somebody at a kitchen table where you could feel their energy. And that was a lot of the teaching that I gave to my agents in my brokerage business, is to understand people's energy and, when you can move forward and when you need to stop, and build that connection right there with them. And it's a new learning process when you're sitting in front of a screen. It's possible, but it's almost like a new skill set that you're learning how to read their energy or feel that and get the same information as you would if you were sitting right beside them. I think that's super interesting.
It is totally a skill set, and all the behaviors that were taught, the things that you do to be polite in person, it's almost an entirely different skill set, but it is a different skill set. How do you act on screen?
And you've turned that into, like you said, you don't even see people in person anymore. You're doing everything remotely, telehealth, as you're calling it, which I think is what a lot of the medical profession calls it. And it's really getting very big. I mean, there are a lot of doctors now that are, my wife has been interacting with her doctors online. I usually have to help her get the iPad going. But nevertheless, that's actually been a thing. So tell us how that's been going for you.
Yeah. I mean, so when I had the idea of creating this company, it wasn't going to be fully telehealth. In fact, I had it all dreamed up in my head of what the location would look like and the services we would offer. I mean, it was beautiful. But it was expensive. And so, when the telehealth law started changing around, 2020, I recognized this opportunity to say, well, I don't actually need a physical space, and I think now that the cat's out of the bag, I don't think the cat's going back in the bag. Mm-hmm. The states it's always changing, so I have an entire law firm that is constantly updating laws to make sure that we're following every state law, because we're across the country, like I said. And that's a challenge, but ultimately, as long as we can stay within the guardrails that are put up, I think it's such a great way to reach as many people as possible. And that's part of our mission, is to reach as many people as possible. And that gives us through our own program, but then also through, social media outlets, et cetera. So we're really pushing the boundaries as far as what we can push out, in a responsible way.
And you said that the law started to change in 2020, and I'm not really familiar with that. Give us the lay of that land.
Yeah. So before 2020, coming from CMS, Centers for Medicare and Medicaid Services, you could not initiate a physician-patient relationship through a telehealth visit, meaning that you had to physically see the person. Okay. And I'm not actually familiar with what happened from there, because that, especially as an orthopedic surgeon, like I couldn't do anything through telehealth, so there was no point in me knowing what existed beyond that. Because of the pandemic, they made that shift and removed that rule. And so then you could create a physician-patient relationship through a telehealth visit. And then that opens up the door. right? And so now there are multiple nationwide telehealth companies, some big, well-funded companies, and then a lot of smaller companies like myself that are spreading their arms to people across the country. So now we have the ability to do that. It's just a matter of staying up to date with the state laws and making sure that you are abiding by the rules, which are constantly changing.
Mm-hmm.
Which is a challenge, I'm sure, all by itself.
It's an expensive one, yeah.
I would think, yeah. Because they don't make it easy. They never make it easy, unfortunately.
Yeah.
Well, they don't tell us, right? You don't get a letter that says that we changed this rule that affects you.
No.
We have to be proactive and be looking for it and making sure that we're abiding by all the laws. But we do.
Yeah. Because, heaven forbid you should actually understand any of them. I mean, that's
Yeah.
really not part of the
Or that
program
there's
here.
any sort of like disclosure
Yeah.
of anything. Like they change any other law, they're going to just disclose it somehow. Like what happened to disclosure?
Yeah. No, they leave it up to us, which is fine. We do it.
Which is admirable. We're very glad that people like you are doing exactly that kind of thing. So tell us a little bit about what the experience has been. You've made this transition. You've got this company going. It actually is going in a way that wasn't quite what you originally envisioned, but it's now, I guess you're 100% online now. Is that right?
Yeah. I mean, so we do have a location. I actually it's really more of a headquarters,
Mm-hmm.
that's close to me here in Asheville, North Carolina. So I do have the capacity to see people in person.
Okay.
So I think that does actually put us in a different category. But yeah, for the most part, we're telehealth, and I would say it's going really well. We've kind of found our niche in certain patient populations, and I've found some opportunities in other patient populations that I'm really excited about expanding into. But my team is nationwide. I mean, I'm able to search broadly for the right people, which makes it really fun. And we have a really great team, and that's probably one of the biggest differences I find when I get reviews from my patients, or, when people reach out to me personally and say, hey, I just want to let you know how things are going. Typically it's that response, which is I'm blown away by how well you guys are able to take care of me. A, because you're not you don't have a physical space that I go to, but B, because your team just cares so much. And there isn't a single thing that I can throw at them that they don't have an amazing response to. So that's really been the big shift versus looking locally. I mean, Asheville's not that big, and finding the right person is always a challenge if you have a pool of very small, very small pool of applicants. Yeah.
That all totally makes sense. It's really interesting too. I mean, if we look at this from the perspective of how a traditional practice would put together a practice in a specialty such as orthopedics, you would probably almost, especially under the current HMO type model that we're under, everything would have been a referral. You would have been, all patients would have been referred to you by a primary care physician. But I'm wondering, is that still true, or do you find yourself getting patients from other quarters? Yeah,
I mean, so my patient acquisition streams. I mean, I have to do my own marketing, so that's a new skill.
Yeah, how about that?
Yeah. So, I was very much in a referral network, part of a big practice, and people came in, and I was the foot and ankle specialist, and I did general work and took call to hospitals. So that's where patients came from. Now, my wife's business, which is still, doing well, and she sees lots of people. I see people coming out on the other end of that business after they've lost, finished their weight loss journey, and then have questions about hormone optimization, thyroid, peptides, all that stuff. So we can put them through a program if they're interested in that. But then also really it's been a lot of word of mouth for the health optimization side, because people are looking for it. But it's hard to market to. Mm. So it's been a lot of word of mouth, really me getting out there and banging on virtual doors like this. Okay. The other side of it, though, is actually working with this kind of newer group that I'm really excited about, which is the bone health group. And I think that people that struggle with osteoporosis, osteopenia, that have had fragility fractures, this is a group where what we do through the health optimization side can easily be manipulated to help people figure out why they're losing bone, how to stop losing bone, and reversing osteoporosis, which is not done in the traditional medical model. So I'm very much excited about that as a way to kind of bridge that gap. Like you said, there are doctors in the traditional medical model and functional people over here. This is actually going to bridge that gap between the two and help support people who are, maybe not exposed to the functional medicine side, but they really want to do both. And I'm really excited about that bridge.
That's very cool.
Can I ask a question about how it works in the States? Because I'm Canadian. So
Okay.
with, oh boy. Yeah.
Interesting reaction.
Oh boy. I don't know if that was a good thing or probably a bad thing.
It depends on your question.
No, I'm just wondering how it works there, because it kind of sounds like if you need a specialist, like a foot specialist or a hand specialist or a bone specialist or anything like that, like you specifically as a specialist, I could just come to you and say, Dr. Doug, please help me. Is that how it works in the traditional model of health? With doctors and everything like that in the States? Or is it more of that bottleneck you were referring to, Walt, earlier of referrals? And I'm not sure if you have to get a referral from a regular doctor to go see this specialist or that one. Like, how does it actually work there?
Yeah, orthopedics is a little bit of a little bit of both. And so in the HMO, like you said, Walt, in the HMO world, in certain insurance networks, orthopedic surgeons are considered subspecialists and you have to have a referral. That's not true across the board though. And so we are typically considered part of that, primary care tier as well. And so you could potentially, depending on your insurance coverage, go and just pick an orthopedic surgeon and go see an orthopedic surgeon.
Wow.
We always tell people, check with your insurance, because they may not pay for it. Which is always frustrating. So so we're kind of in between. And then, how it works in Canada, I have no idea. I
know how it works here.
Yeah,
Everything is a referral. Like, you got to go to your regular doctor, and then if they agree, they can send you for a referral to a specialist, and the process takes months. Like right now, my father-in-law, for example, has been waiting 2 years for a specialist to check out his back because he has a disc problem. So the average wait time for hip surgeries, things like that, is years.
Yeah, I mean, I have some colleagues who operate, or they live and operate out of Canada, but they also have a practice in the United States. And so when they finish their allowed number of surgeries, then they exit. They exit that system and they enter our system, and they do basically private cash pay surgery down here. And it's interesting. We can talk about that. I don't know enough about it to talk about it from an educated perspective, but I hear their complaints enough to know that it's challenging for patients.
Very
challenging.
Mm-hmm.
Yeah, and for doctors, that's right.
Yeah.
Challenging across the board. I'm also interested in how do I describe this? In the way that patients perceive what you're doing. I don't know a particular word that describes that, but you indicated that people seem to be responsive to it and liking it to a certain extent. Are you running into any challenges where people are saying, "Oh, this isn't working for me"?
No, I mean, the biggest challenge is that we don't accept insurance, right? And so people in the United States have gotten to a point where people want insurance to pay for everything, and we don't accept insurance for reasons I'll talk about. As far as the actual care, no. I mean, people, what they get out of working with us, learning about their genetics, looking at an extensive lab panel and actually figuring out risk factors for heart disease and dementia that they don't get otherwise, micronutrient deficiencies. I mean, these things are so impactful that help them to answer these questions, of should I be taking this supplement or that supplement, or, having the discussion about hormones especially for postmenopausal women who are like, oh, I thought it caused breast cancer. Like, well, no, not for most. So having the time to have the discussion for one, and then learning that information. I mean, no, I've never had anybody walk away and be like, no, that was a waste of money. Cause even if they did nothing with it was still worth the price of admission. Mm-hmm. But the challenge with insurance is, we make it very clear up front. So I don't have this conversation that often, but occasionally people will they'll slip past all of the guardrails. And they'll get to me and they'll say, well, why don't you take insurance? And the answer to that is insurance doesn't pay for our services, for one. I could submit a claim for a code to see a patient, and I would get paid whatever my negotiated rate as a very small provider would be, and it'd be like $30, and I can't support a practice because I spend an hour with my patients and I spend an hour prepping for that visit. I can only see how many patients a day. If I spent the whole day, it's 5 patients, right? So I can't make $150 a day and actually even afford to feed my family. So for that reason, we don't accept insurance for our services, But then so many of the tests, the functional tests that we do are rarely covered by insurance. And if they are, they don't cover it completely. And for me to actually bill it through insurance, I would have to have an army of administrative people, which cost money, to try to get it covered for you, which would ultimately then cost more, to actually like get the little bit that your insurance company is going to pay for it. And then there's the labs, and the labs is a whole nother racket where the insurance rates for blood labs can be 100 times the cash pay rate. I mean, it is ludicrous, the markup that insurance companies charge essentially the consumer. And this is all worked out and negotiated with the lab companies. But if I go directly to the lab companies and pay cash, I get the cash pay rates, which then I pass on to my consumers. But if I file it under insurance, then we're paying the insurance rates. And you can imagine what that looks like. So to avoid all of that, we just step away from the insurance model. And I tell people, look, there is an accepted level of care that you can get through the insurance model. And it's different in different countries, right? Fortunately, the level of care that you can get in the United States is still, it's reasonable. It's not bad. It's not optimal though. And so that's where I say, look, if you want optimal care, if you want to optimize your body, then that's outside of the insurance model. You shouldn't expect your insurance to pay for it. If we think about car insurance, right? Like if you buy, I like to use the analogy of trucks. People love, this is, North Carolina has a lot of trucks. So, you want to buy, an F-150 and you want to get insurance to cover if you have an accident, right? But you don't ask your insurance company to pay for your gas. If you want to jack up your truck, you don't ask your insurance company to pay for the suspension and the new tires and the new wheels. So it's the same thing with your body, right? If you want to optimize your body, that's a surplus, right? You got to invest in that. And you don't have to. But I think you should. And I think we all should. Because after you go through a program like this, you recognize, okay, this is how I prevent myself from needing those other services that I have insurance for.
Yeah, prevention is an interesting topic all by itself because, first of all, the way it is prevented often in the mainstream medical community, but also because of the way it's presented in the alternative communities. And you're somewhere in the bridge in the middle. I'm not sure exactly where to place yours, but nevertheless, you're dealing with the same general issue. In other words, how do you actually approach it? Like I can think of a couple of jokes that come to mind, and they aren't all that funny now that I think about it. But the one joke being that they talk about healthcare, but the hospitals are full of sick people, that kind of thing. Right. How much are we actually talking about health here? I think that's the first question that always comes to my mind. Are we talking about health or are we talking about disease prevention? Because to me, they're not the same thing.
They're not. And you're absolutely right. I mean, if you think about where our system has gone, we don't really cultivate health through our healthcare system. We treat disease. And we have prevention models, but they're very weak. And one of the arguments I get for insurance is say, well, shouldn't my insurance company want me to be healthier? And my answer is not really. So think about what an insurance company is. They sell a product, they make profit, and they have shareholders, right? I mean, it's just, they make widgets like every other widget maker. And their widgets make a lot of money. And if you think about what the journey is for a client in that widget company, insurance companies generally will have a customer for 3 to 4 years. So they don't actually care, if you're 20, they don't care that they're preventing dementia when you're 60. That's irrelevant to them. It's irrelevant to their shareholders. Not that they don't maybe emotionally care.
Sure. But it doesn't
but that's not
any money on the bottom line.
That's not the business model, right? And same thing with the way that our reimbursement is set up for providers. If somebody came to see me as an orthopedic surgeon and they didn't need surgery, I get paid to operate. So that's kind of a wasted visit for me. I mean, I can bill a code for that. But again, like if I'm spending more than 5 minutes with them, that's a wasted visit for me. And it's really unfortunate, but even somebody like myself who clearly has some ethics around talking to patients and explaining things, I still struggle with that. I got to get through my 50 to 60 patients in an 8-hour block. And that you start doing the math on that. Yeah, you're right. You start doing the math on that and you're like, whoa, that's tight. That's a lot of patients. And it is a lot of patients, and so now in the way that I see people, I have probably max 4 or 5 patients a day.
Wow.
and we spend a lot of time together, and they have constant access to me. My patients have, we have a chat feature through our electronic medical record, and they can access me anytime. Doesn't mean I'm going to text them back at 3 a.m, but still, if they have a question, they could drop it in and they know I'll get back to them.
Yeah.
And that's the kind of care that I like to be able to provide. Is
That's
that
a throwback.
scalable? Yeah. I mean, is that scalable? I think it actually is, but how do you create a system where you could do that on a broad scale? And it's an interesting question that I haven't really thought about because my practice is very small.
Because I can remember when I was like 4 or 5, it was at the tail end of the period where you could still get a doctor coming out for a house call. So I can remember being 3 or 4 years old and the doctor coming to our house, and then that stopped because it was right at the transition point where the medical practices wouldn't do that anymore. Now you had to go to them. And from that point on, the appointments got smaller and smaller and smaller, and they're trying to squeeze more and more in. So to actually be talking to somebody who has found a way to spend time to talk with the patient, that's a throwback. That goes back 50 or more years. That's really something.
Well, and it's funny, the irony, right, that I'm actually going into people's homes through telehealth.
Yeah.
Yeah.
I mean, it's actually it's kind of a house call,
Yeah.
and it's fun. So, I'm sitting with them in their kitchen and in their home environment, they're comfortable.
Right.
And we're having a conversation about things that really matter. Like, how much sleep did you get last night? What do your sleep behaviors look like? When do you stop eating before you go to bed? What do you think about when you wake up at 4 a.m.? These things that your doctor's not going to ask you because they don't have time.
Yeah. Yeah. It's not necessarily that they don't care. It's that they don't have the time to spend with you.
For sure. And that's part of the feedback that I get from physicians to say, well, yeah, like I'm interested in those things too. Like I want to talk about those things, but I can't. And I say, like, I'm not saying that you don't care. I'm not saying that you're providing bad care either, and I get this feedback, especially from the OBGYN world when I start talking about the differences in how I do hormone replacement versus how they do hormone replacement. I'm not saying you're a bad doctor or that you're doing it wrong. I'm just saying that the philosophy is different.
Mm-hmm.
You're following the guidelines from your college, and those guidelines are based off of what they're FDA approved for, not necessarily what the research says that they can do.
Mm-hmm.
And it's just a different philosophy. And so, that negative feedback is frustrating because a lot of times they just get defensive, and it's mostly because I think that they know that they want to do it differently, but they can't.
Yeah.
Do you see that changing?
No.
No. Okay.
No. I mean, I have a pretty pessimistic view of where our healthcare system is headed. I think that we're going to see more and more people like myself. I mean, we saw, I forget what the actual statistic was, but over the last 2 years, the number of physicians that have left the traditional medical model or have, early retired, it blew my mind. And I wish I could remember what the number was, but it was a very, very large number. And we're already facing a physician shortage. So what is that going to do to the system? And I'm guilty of this too, right? Because I walked away. What is that going to do to the system? It's going to make the deficiencies in care worse.
Sure.
And it's going to make it worse in areas where care was already not available.
Mm-hmm.
It's going to make the care in the current system worse. But the plus side is that as more of us are creating businesses like mine or joining together to create larger organizations, we're going to create a tier of care that is going to be more broadly available to help people to truly get to where they want to be. So I think it's going to be a rocky road, but I think we're going to get to a different place. It's going to look a whole lot different 10 years from now than it did 10 years ago.
Mm-hmm.
Yeah, I think it's definitely true. I'm glad to hear you say that. I want to ask you something a little bit too about the actual treatments you do. You talked about hormone replacement. You made reference earlier to osteoporosis and other bone related diseases. First thing I want to ask you about, this may sound out of the blue. I've heard a truism, and I don't know if it's true. Is it true that most women have osteoporosis when they get past 50 or so?
I mean, in my world, it sure is. The statistics are actually really concerning. And I don't think the statistics are even actually paint an accurate picture. And so the reality is that 1 in 2 women in their lifetime will experience a fragility fracture.
Wow.
1 in 2.
Wow.
Right? That's 50%. 1 in 4 men. And a lot of times we don't think about men having poor bone health, but it's true. And the reality is that it's going to get worse and worse as we get older because our bone health if you look at why people lose bone, there are a lot of reasons, but a lot of them are happening in a lot of our population already. Mm-hmm. And so we reach peak bone mass very early in our life. So, early 20s, you reach your peak bone mass. And so I don't know any 22-year-old woman who is thinking about getting adequate calcium and vitamin D and eating well. I mean, maybe again, this is the world I live in, but how many of my patients that are in that age group are chronically dieting, have eating disorders, they're getting really poor nutrition. They're trying to stay as skinny as possible. And unfortunately, that's going to have a huge impact. And it's been like that for decades. So this is not new. And so now what I'm seeing is that women, to answer your question, women, as they go through menopause and they lose natural estrogen, testosterone, and progesterone, they will see a precipitous drop in bone mineral density. That's only a big problem if your starting point isn't very good. The more you drop the starting point, the bigger that problem is. And so women are seeing, I think fragility fractures earlier. And even before, the recommended age for screening is 65, which is woefully too late. But even before they go through menopause, we're starting to see, hip fractures and spine fractures and women that have never been screened that don't know. And they haven't even gone through menopause yet. So yeah, it's a big problem. So do all women have it? No, but a lot of women have it.
And now that you mentioned that can affect men too, now I've got my eyebrows up. I'm thinking, okay, how much time do I spend walking out in the sun? Oh yeah, well I'm out there for an hour a day in my shorts. Well, that helps some. Okay, that's good. What else can I be doing?
Maybe, Walt. Maybe. Yeah. Walt, where are you, Walt?
I'm in Connecticut.
You're in Connecticut? Yeah, you're not getting any vitamin D in Connecticut, Walt. Even if you're in the sun.
What?
Well, now I'm really enthralled here. Okay.
Yeah.
Yeah. That really only works if the closer you get to the equator. No, it's really hard to get enough vitamin D naturally. And there are so many reasons why people don't absorb calcium, adequately. So yeah, it is, again, this is something that's why I'm so excited about pushing this out, because it is a massive problem. And there are a lot of things you can do that are very simple. And those are the things that we're going to try to push out again through social media channels and just, get the word out. Because this is one of those spaces where, just like you said, like you're an educated guy. But to think that you're going to be in Connecticut and the UV rays are going to actually produce vitamin D on your skin, for the limited time that you're actually outdoors, it's just not true. I test vitamin D in all my patients and I've never seen it optimal in anybody that isn't supplementing.
So that raises the obvious question, what's the best way to supplement it?
Yeah. So, in general, these are not specific recommendations, but in general, no, the research right now is pretty good that if you consume vitamin D3, and this is just very clear on an over-the-counter supplement, D3, they're both writing it down. Yep. D3 and vitamin K2, take them together to increase the absorption of vitamin D. And then the vitamin K will actually help not only to absorb the vitamin D, but it'll help to put the calcium that you're going to increase the absorption of in the right place. Because there's some fear that if you're taking calcium as a supplement, that it can go into your arteries, which is true. But if you take vitamin K, it can help to prevent that and actually potentially reverse that.
Wow.
Okay. And then the calcium itself, there's a lot of controversy about what forms of calcium to take and how to take it and so forth. So what's the recommended scoop there? Yeah,
the scoop there is that there's some good evidence to say that calcium hydroxyapatite, and you can just loosely spell that and Google will correct you. But hydroxyapatite, that's the form that it exists in your bones. So if you take that same form and supplement, there's good evidence to say that it'll actually improve your bone mineral density better than taking any of the other forms of calcium.
Okay. So there is actually a reason to be concerned about some of the other methods that you can take calcium.
Yeah. Well, so if you look at things like calcium carbonate, it's just not absorbed at all, right? It's like eating chalk. It doesn't really do much other than go out the other end. But other forms of calcium like citrate is reasonably well absorbed, and that's generally what's recommended by bone health experts. But the question is then where does it go? Because we don't want to calcify arteries. We don't want to calcify other tissues, because calcium in tissues causes inflammation.
Right.
Interesting. Yeah.
Yeah.
I can see how this becomes a very complex topic in a very, very short period of time.
And that's the challenge, because there are some sources for information out there, but if you don't have the right context and if you don't know that it's right for you, how do you know that you're doing the right thing? And so I see people come in that are on all over the place in the spectrum of supplements, and people that are taking, they're taking way too much calcium, or people that are so afraid of it that they're not taking any. Then they've also made the recommendation of, well, I'm going to eat a plant-based diet for my heart, and I'm going to do this, and I'm going to do that. And they're not eating any protein at all, and they're just withering away. I'm thinking, stop! No, let's fix this, please. We can make a change here. So it's really hard to know how to put the dots together based on what your goals are.
Yeah, until you do like the backup of what I assume is what you guys do at OHH. Is
That's
all
exactly
the blood
right.
work
Yeah.
and all of that. Yeah.
Get all the information and then figure out who you are. Right. And so, okay, well, this is your lifestyle. These are your goals. These are your genetics. This is your extensive blood panel. And this is what you look like on these functional panels. Okay. Now let's put together the map. And that's why it takes me an hour to prep for these results reviews, because it's a lot of information, and it comes together in our health report, which right now this report just keeps changing, week by week. But, how do you put all that information together for somebody in a way that they can understand it without a PhD? And that's the challenge. And I think we do a really good job of it. But we're always trying to make it better. It's fun. I mean, it's mentally challenging for me, but I love it.
I'm thinking about my wife right now because she's in retirement age. She's 68 now, and she has been told that she is calcium deficient in her bone structure, and nobody among her friends were surprised. And of course, she was told basically, take the calcium and vitamin D. And the first thing that comes up with her is she hates taking pills. She actually had Graves' disease at one point, hyperthyroidism, and they told her she was going to be on medication forever, or she was going to have surgery or have it burned out or whatever. And it got to the point where the dosage was so high, they said it's an absolute guarantee you're going to have to make a decision. And we didn't buy a word of it. We didn't buy into it at all. And then about a year later, they started cutting the dosage, and they cut the dosage more, and they cut it more, and they said, well, we're going to have to take you off a bit and see how you do. And that was like 3 years ago. So she beat it. She actually got her goal. She got off that pill merry-go-round. But because of that, especially with the way calcium tends to come, she has an aversion to taking calcium. So, are there alternatives for her that?
Right. Yeah. It comes in these big horse pills, right?
Yeah. Which is like the last thing she's interested in taking. Right.
Yeah. Yeah. No. I get that. So are there alternatives? Yeah. Get it through your diet. That's actually the way we want you to get it. But you got to do the math, and you got to make sure that you're actually getting it through your diet. And then you also have to make sure that your gut is functioning the way that you want it to, which is to actually absorb things. And so that's where the testing comes in. Because you really don't know. I mean, some people that have significant gut dysfunction have a lot of symptoms, but a lot of times you don't know. Like, you don't know that you don't have good hydrochloric acid and that you're not breaking things down and absorbing calcium. And so those are the things that we look at.
Okay.
So you guys draw all of those conclusions. Sorry, Walt. Of like whether your gut is actually absorbing what it's supposed to. Wow.
Yeah. Through our health optimization programs, we do that a little bit. We do more of like a gut screen and see, unless people have a lot of symptoms, and then we can tweak that. But for our osteoporosis folks, we do a pretty full on approach to looking at the gut function, gut permeability, or leaky gut, as a lot of people call it. And then a little bit of food intolerance early on, and then we can expand that later if we need to.
Okay. But it's definitely something that needs consultation. It's something that you have to kind of get a one-to-one screening.
Yeah, it's really hard. I mean, it's hard you can order the functional. Well, it's not even true. Sometimes the functional test you can get on your own, depends on which test you're talking about. But then what do you do with it, right? How do you interpret these? It's really complex. That's why I did 2 fellowships after my other fellowship. Cause it is complex. There's a lot of information, and there's a lot of, there's ambiguity in how the results are delivered, and then what do you do with it? How do you actually treat it?
I can see no wonder you're busy. I mean, it's very clear to me just on that alone. And we haven't even touched this hormone replacement or whatever that is. We haven't even touched that yet. So it's very clear why you're busy. But why don't we touch that part? Tell us about the hormone part. What's that?
Yeah. So this is something, early on I thought, gosh, there's no way that I want to do this. I just don't know enough about it. It scares me, right? Like, it scares most physicians. I just don't want to deal with it. And then I started working with patients and realized, I can't rely on the OBGYN or primary care docs to understand it or to deal with it. And then the more I learned, I realized that, where there is just so much fear and dogma in the world of hormone, I don't even want to call it replacement in the traditional model, because it's not, it's symptom management, that I have to do it, so then I went and got more training. And so now I do a fair amount of bioidentical hormone replacement, particularly in perimenopause and postmenopausal women, but also now for premenopausal women too, because as it turns out, the hormone problem doesn't start as you go through menopause. And then also for men and testosterone replacement therapy.
And talk about why someone wants to pursue this. What's the motivation behind it?
Yeah, so it's different for different genders. So men, we'll talk about men first because they're easier. So for men, there is a predictable decline in testosterone as we age. You could argue whether or not that's natural, but it goes down as we get older. But the problem is the starting point, just like women in peak bone density, the starting point for testosterone is getting lower and lower decade after decade. Our culture in society and our environment is all kind of against testosterone, and that's a long conversation. But basically, testosterone levels are dropping. And so now, as you start to lose your testosterone as you get older, it was already low to begin with. I mean, I see low testosterone in men in their 20s. And so, where are they going to go? So it goes down. And what people notice when they have low testosterone is really it's fatigue, it's brain fog, it's lack of vitality, lack of competitive edge and competitive nature. Those are the things that I like to treat testosterone testosterone deficiency for. Other things that you hear a lot, it's like people talk about, lack of libido and erectile dysfunction and those kinds of things. And yeah, that's true too. But really what I find men are looking for, it's the edge, it's the vitality. I think it's probably like the best word to describe it. Mm. For women, we'll just focus on postmenopause to keep it clear. But for postmenopausal women, there is obviously it's like their hormones drop off a cliff, right? So you go through menopause, your hormones fall off the cliff. You have essentially no estrogen, very little progesterone, and very little testosterone. And again, you could argue that is natural, as is aging, kind of. But I like to look at aging as a disease, and loss of hormones is a symptom of that disease. If you want to fight that disease, which I want to fight that disease, if you want to fight that disease, you need to optimize your hormones. So when you look at it from that lens, then what do you do with a postmenopausal woman who has no estrogen? Well, you want to optimize her estrogen, right? I want to put her estrogen levels back to where she was before she went through menopause, because it can help her with her symptoms of menopause, which is what estrogen is FDA regulated for. But also because if you look at the literature, it can help to prevent bone loss in menopause. It can help to keep your lean muscle, mostly testosterone, but testosterone can help to maintain your lean muscle mass. It helps with skin quality. It does all the same things that I just said for men and women. Progesterone helps with sleep. Progesterone helps with the cells that make bone to keep them going, and it balances your estrogen. It can help keep your vessels, your arteries flexible, so it can help prevent heart disease, prevent stroke, prevent dementia, prevent diabetes. I mean, all of this stuff is in the literature, but the FDA says, no, you can't use it for that.
Wow.
And so bioidentical hormone then is, we are using these things off label for symptoms of menopause, which is legal. It's ethical. I think it's probably more ethical. But it's not, that's why most doctors will say, well, we don't use estrogen for osteoporosis. And I agree. You don't use estrogen for osteoporosis, but I do use estrogen if I want to help somebody to prevent bone loss from menopause. Right. So it's just how you spin it. So I do that. And my patients that had dysfunctional hormones, once they're optimized, happiest patients. They're really happy.
Wow. So since I'm on the male side, I'll let Jody bring it in from the female side. I'm on the male side. Since I'm on the male side, vitality, that definitely sounds appealing to me. I'm 65 and vitality isn't what it was, 20 years ago, let alone 40 years ago. So what can I, if I go through your program, what can I look forward to?
Yeah. So again, what I notice in men who start on testosterone replacement is really it's that energy, it's the drive, the fact that I want to get up, I want to do my work or whatever my tasks are. I want to work out, and I would tell somebody your age, hey, you really got to actually do resistance training. We have to fight that loss of muscle mass. As we get older, it gets harder and harder to maintain muscle mass, and muscle mass is our longevity organ. So you got to do more, and testosterone gives you that oomph to go do more.
Okay. Well, that's the elevator sales pitch right there.
That's right.
Yeah.
How about from the female side, Joe? Do you want to take a crack at that?
Well, I feel like there's a couple of things that I was thinking about. I'm not post menopause yet, not there, but it's
I wasn't going to ask you that.
Yeah. Smart man. No, I'm only 37. So still like working in trying to have a baby scenario. It's so interesting, Walt, that this has come up, like fertility and hormones or whatever. Week after week, we've talked about this. Mostly like off screen. I pelt the individuals we have about fertility, but here we go. We're just going to do this live. But one thing I thought is interesting about that post menopause, I know tons of ladies who are in that space. One friend I have who her doctor is saying her hormones don't match with her going through menopause, but she hasn't had that cycle for years. And they're like, oh, we'll just wait. It's kind of like, oh, we'll just wait another 6 months and do another test. Like, I'm sure it'll show up. And she's like, what's going on with my body? And I was just talking to somebody last night who was having problems with all of these things now in menopause. So I think it's interesting the way that you phrased it. It's sort of natural, but not exactly natural, that these jump off a cliff. And I want to know more about that. And I want to know more about the premenopausal and cause I think we're just really women in general, myself included, especially not educated on what our hormones are supposed to be, what we're supposed to do with them, what a period is supposed to be like, what any of this is supposed to be like. It's like, don't talk about it.
Right. Yeah. So, I mean, so to answer the first part of your question, that natural hormone change. If you think about the life cycle of any animal that has a menstrual cycle and that eventually dies, there is going to be this point at which they stop having menstrual cycles, and then they go through the remainder of their life, and then they die. So it's natural. But again, if you look at aging as a disease and not as an inevitable, then it's a symptom of a disease. And so it's a different perspective. And so I would say that you have a symptom of aging, which means that your ovaries they're telling me that your ovaries are no longer making estrogen. That cycle has been disrupted. So then what do we do about it? We can accept it, and then we can know that there are some things that are predictably going to happen, like the loss of bone mineral density, the loss of bone quality, your muscle mass, your skin's going to change, like all those things that we know that happen in postmenopausal women predictably because they don't have estrogen. So that's the way that the traditional medical model looks at it. And that's why the FDA also says estrogen is only FDA approved for symptoms of menopause, not for any of those other things that I just mentioned, because they're only interested in helping you get through the menopause.
Right.
As far as premenopausal women, boy, it's a really interesting space, which again, like, I never thought going through orthopedic surgery training, as I'm learning how to fix bones and plates and screws and, big intramedullary nails, that I'm going to have a practice where I'm talking to 20-year-old women about their cycles,
Yeah.
Never thought that would happen. But the reality is that it is important. And this is not a knock on the OBGYN community, but the traditional approach to women that are having dysfunctional cycles frequently is go on birth control, and we're just going to make your cycles work based off of this pill that we're giving you. Mm. The problem with that is that birth control, as it's given, with the synthetic progesterone and the estrogen that's given, if it has estrogen in it, they're synthetic, and they have consequences. The increased risk of blood clot, the increased risk of all kinds of other things that people don't talk about. And whenever I see a woman that's on an oral birth control pill, I get her off of it right away and say, look, if this is for contraception, let's use something else. If this is for irregular periods, let's figure out why you're having irregular periods. Like, this is the functional medicine, like the root of functional medicine, which is, why do you have the symptom to begin with? And maybe you do need progesterone, but let's use a bioidentical progesterone that you take as a capsule. For women that are cycling, very rarely do they need estrogen. But for the rare of those that do, let's do it in a way that you're actually getting the estradiol and the estriol that your body would naturally make. So your body knows what to do with it. And so it's definitely much more challenging. It takes a lot of time. And I think that's part of the issue too, is it takes a lot of time. It takes a lot of trial and error. And when you're doing that in a traditional office, you just can't do it.
You don't have the time.
Somebody comes in and right, they're having heavy bleeding or their periods are dysfunctional or whatever, the bad PMS symptoms. And it's just, you write a script for oral birth, control and you're done.
Yep.
Yeah. So.
Or the depot shot. That's a big one here.
Right. Well, and again, like that's the same progestin. That's the same synthetic progesterone that has all of these known potential risks. And yet that's the go-to.
Yeah.
Because it's easy.
Mm-hmm.
Yeah.
Yeah. It's very frustrating.
Yeah, for sure.
I'm really intrigued though by what you're doing, because really, from my perspective, this is my way of looking at it. From my perspective, what you're doing goes back to what we talked about at the beginning of the show. We talked about how the medical community is resistant to change and all that kind of stuff. But really, since the medical community is ostensibly based on science, science is about curiosity. I mean, it has kind of evolved to the point where science is all about covering your butts and making sure that nobody can come along and steal your cheese. But really, science is about being curious and trying to understand and follow and investigate, right. Acquire the data and then understand the data and see what theory you can create out of it. And then you find your theory doesn't work. And so you get some more data and you learn some more. That's what science is all about. And that's right. More along the line of what you're doing now, which is really commendable. That's
actually the scientific method. You're right. Yeah. Ask a question. Try to find the answer. And then if you think you found the answer, ask the same question and see if you can find the same answer again. If you find the same answer again, then maybe move forward with that. Mm-hmm. Right. Not this like, ooh, I think I have an answer. Let's do something with it. That's the world of nutrition, which is let's like come up with a theory and then let's just impart it to the world. Like, whoa. You skipped a whole lot of steps in there. And that's what we've been dealing with, for the last 70 years in the world of nutrition. It's like some self-proclaimed expert has a theory and they have very powerful influences in government. And then all of a sudden we have policy, it's like, well, wait, like go back to the whole, the diet heart hypothesis. Why did we think that dietary fat was bad for you? There's a single guy who had a theory that was actually opposed by most and created, government regulations that just, I think really started the obesity epidemic.
We could probably do a whole show on that, but unfortunately, we don't have enough time.
We should.
For that.
Yeah, we don't. You're right.
Well,
yeah.
we'll arrange that.
Next time.
I'll tell you about something after the show that actually could lead to that, because I have an idea going in my head, but we'll bring that up another time. For the moment, we have to kind of draw this to a close. And before we draw it to a close, we need to get some information from you, because undoubtedly there are listeners listening and saying, I should check into this more. How do they check into this more?
Yeah. So, easiest way is just to check out our website. So we're at optimalhumanhealth.com. And on that website, we have, an area for blogs, which we're trying to write and get as much up as we can. Obviously, it's a lot of different information topics. So we're doing the best we can to get as much information there. You can follow us on social. So, these will all be, I'm sure, in the show notes, but my name and the name of the company. And then we also have a new website for the bone health side, which is optimalbonehealth.com. And so that is very specific to bone. And our goal then is, of course, to educate people through that platform as well. If you want to learn about how you work with us, just go to those websites, you fill out a form. And typically we onboard people by having an initial interview. So I actually just meet with everybody that wants to work with us and talk about whether or not we're a good fit.
Very nice.
Wonderful.
Jody, I don't know about you. I learned a ton today.
Yeah, it's fascinating. Right? And I love that this keeps coming back around, because I think it is a huge component. And I'm so excited to see this shift, in doctors saying, I want to do more the way that you are, Dr. Doug. I think that's so beautiful. And I can't wait for that to catch on in Canada. Not that they don't care, but just that they're taking a different road like you are, or maybe, practices like yours start to open up internationally. Who knows?
Yeah. Who knows? Yeah. Well, it's been fun. I appreciate the conversation. Thanks, guys.
Thank you for joining us. And we will include in the show notes how to reach both the Bone website. You'll have to give me the other one too, because I don't think I have that one.
Sure.
So I'll get that information from you so we can get that into the show notes. But thank you once again. And Jody is not going to be able to join us next week. She has a pressing engagement, but she'll be joining us the following week. So we'll look forward to that. And we will have a guest next week. We'll give you some more information about that. But in the meantime, we'll just say thank you very much for listening. And we will see you all next time here on LOA Today. Goodbye, everybody.